This is Dr. Shivayogi.
Yeah. She's a founder and chairman of Kusagur Eye and Skin Hospital, Davangere. Yes, Dr. Shivayogi. So we look forward to knowing a lot more from you about intubation and removal. On to you. Are you there?
Yeah, I'm very much.
Yes.
Is my slide visible?
Yes, very much visible.
Yeah. At the outset, I would like to thank AOS, Dr. Chitra, for inviting me for this beautiful webinar on DACRYOLOGY. First time in my lifetime I am attending a webinar or a conference on DACRYOLOGY. Simply, we are tear wipers, isn't it? So whenever somebody asks, what are you doing? I just tell, I wipe the tears of the patients. Anyway, that was a very good and nice discussion, previous speakers. And my job is to speak on the intubation and removal and everyday practice. I practice in a place called Davangere, that is central Karnataka. It's around 4 hours from Bangalore. And most of my practice is lacrimal surgery. And I do exclusive oculoplasty since last 12 years in this place. So you all know that stents are small diameter tubes placed within the nasolacrimal system to maintain the patency. There are a lot of materials which were described earlier, and nowadays the most commonly used material is silicone, as you all know, and silicone is being used in other subspecialties of ophthalmology also. This stenting is a temporary process, but in some cases it might be kept for a long time also. This stenting is also used in laceration of the tear drainage system or any trauma to this tear drainage system. My practice here in my place, I use only 2 types of stents, that is the bicanalicular stent, that is the Crawford tube, and the monocanalicular stent, that is the miniature of a monocast stent, that is mini monocast stent. What is an ideal stent? An ideal stent should have all these properties. It should be inert, pliable, self-retaining. It should be smooth. It should have a smooth external surface so that you can stretch it. It should be easily available, and most important of all of these is it should be affordable to a common man, because people like me practice far away from Bangalore and the affordability is slightly less when compared to Bangalore. So as already I have told, we have bicanalicular and monocanalicular stent. So what is a bicanalicular stent? It's also called as Crawford's tube. The bicanalicular stents pass through both upper and lower canalicular system, creating a closed circuit. We should remember this. This is a closed circuit. They can intubate the upper, lower canalicular connecting via the common canalicular system. They can also intubate the entire nasolacrimal drainage system, including the lacrimal sac, nasolacrimal duct, with circuit being either open or closed, as in this case when we intubate a child with a nasolacrimal duct obstruction. On the contrary, the monocanalicular stents intubate either the upper or the lower canaliculars, especially in trauma. In other case, like a surgical procedure, which can create a pathway of the stents to be placed directly into the nose, as in this case when it comes to Lester-Jones tube. As I previously told, I use mostly the Crawford stent, which is from the Orolab, that is Orolac, which I prefer. That is my stent of choice. I don't have any hesitation. It involves the entire nasolacrimal drainage system. It's a bicanalicular stent. It has a bulb. This is very, very important when you are purchasing bicanalicular stent. Always look for this bulb and the attachment here. So this attachment is very, very important, because whenever you pass, this might tear away. So this tube should be well over this aluminum foil, and it should be bulbous at the end, so that you can easily pass into the canalicular system without causing any damage to the epithelium. Mind you, if you damage the canalicular epithelium, it's going to cause fibrosis in the future. So not much of a Rittling stent was designed by Dr. Rittling. This has a stellate. It's again a bicanalicular intubation, and once it is inside, the stellate is removed, and the one end of the bicanalicular stent is advanced through the hollow lumen of the tube, and it's repeated via the opposite punctum. Not much of use nowadays. Pigtail donut stent involves the upper and lower common canaliculi. It's a commonly used in traumatic canalicular laceration repairs where patency of the nasolacrimal duct is intact. This is a recent stent which the FDA has approved in 2012. This is called Kaneka Lacry flow stent. So this stent is made up of central thin intracanalicular portion, and this stent has a wing here, a couple of wings here and here. So what you have to introduce this through the upper canalicular system, and once you are into the common canaliculars, once you are towards the lacrimal sac area, then just withdraw this, holding this tube, and the same is repeated with the lower canalicular system. I don't have any experience with this. This is a new stent. If somebody has an experience, please kindly throw or enlighten us. What I would like to highlight is this is a GRU director, which is designed by me. When I came out of Arvind, I was not getting a GRU director. So once when I was eating the ice cream, I saw this ice cream with this spoon. This is called Gadbad spoon. So what I've done is I've decapitated this spoon and bent a little here and smoothened this area, which acts as a GRU director, which is used for intubation of bicanalicular Crawford's tube. So this is the spoon which you can see in the nose, and the tube is being passed, and the metal rod which touches this spoon and comes out of the nose like this. So this I call it as modified GRU director. On the other hand, this is the mini Monaca stent, a miniature of the Monaca stent, which has a tail. This is the head and the neck of the mini Monaca stent. So it involves a single canaliculus. As I've already told, it's a silicon stent which is anchored at the punctum by a plug or a cap at one end. It's used to treat canalicular stenosis or canalicular laceration. So whenever there is a canalicular laceration, you have to pass this tube through the punctum, and this snugly fits into the punctum, and the other end passes through the cut end of the canalicular system. So this invention of this mini Monaca stent, or availability of mini Monaca stent in the Indian market, has totally changed the canalicular laceration or canalicular tear. If you can remember, in our resident times, we used to pass the IV Venflam into the lower canalicular system and try to tie it over the near the punctum area, and invariably it used to come out, and a lot of fuss with those Venflams and IV cannulas. So availability of this mini Monaca stent, again thanks to Aurolab, which is supplying Aurostent, and I use a lot of these in lower canalicular tear or upper canalicular tear. So Jones tube, again it's a Pyrex tube, a glass tube. Don't have much experience. When I finished my fellowship, did some 10 cases, and which I brought it from Arvind Hospital, asking Usha madam, and the results were not that good, and these tubes can be directly put through the carunculectomy wound and directly into the ostium. You can place this, and you can suture this end to the conjunctiva, and this goes into the osteotomy. So coming to the stent removal, this again, there are the techniques for stent removal depend on the type of stent utilized. Crawford stent, I tend to remove at 4 to 6 months. There are two approaches, endonasal approach and the open approach. Through the eye, you can remove endonasal through the endoscope. If you have in your OT, just go into the nose and try to identify the knot and just cut it and remove it. It's easy. I mostly do the stent removal from the eye side, where I identify the stent and cut it and try to remove it through the nose. So this is a office procedure, OPD procedure, and try to remove. I'll try to remove after 4 to 6 months. So most of my, in my experience, if you ask me, if I do around 10 failed DCR, so in my experience, in this part I'm talking about, so 8 of the failed DCRs, they are like a primary DCRs to me. I mean, when I open, the MCT is intact, the bone is intact, everything is intact. So roughly around 70 to 80%, they are like primary DCRs to me. Around 2%, you can say, or 20% are when I use these stents. I don't use in all failed DCRs. I try to use stent in facial fractures when the patient comes with a fracture, or when I feel the common canalicular area is fibrous because of previous surgery. So in those cases, I would like to use stent along with mitomycin C. Mini Monaco stents are removed by grasping the header and pulling it out from the punctum. It's again an office procedure. Rittlings are removed again in the similar fashion as the Crawford stents. The canalicular lacrimal flow stent is removed by simply pulling the export stents, and the Jones tube. Usually we try not to remove it, but again you have to cut the suture and you have to remove it if you want to remove it. So this is a video. I don't think, yeah, this is a small video where I am removing the Oro stent, that is mini Monaco stent. Coming to the complications of stenting, prolapse of the stent. This is a very common complication when my resident calls me, sir, case has come with prolapse. So this prolapse can be managed. The small prolapse can be managed. Just try to put it using a tooth forceps, try to put them inside. This goes inside and then anchor the knot in the nose. Whereas if you have a large prolapse like this, so you need to check the knot through the nose and bring it back and then suture it. So that is one complication. You have some complications like this when there is a foreign body granuloma like this. You cut and remove, again there is a granuloma. So in that case, you have to remove this bicanalicular intubation. Sometimes there might be damage to the puncta when you have excess tension and there is cheese wiring of the puncta. Granuloma we have already discussed, and infection of the nasolacrimal drainage system reported in some literature because of contamination of the intubation with organisms such as non-tuberculous mycobacteria. In summary, stents indicated in punctal and canalicular stenosis, they restore normal epithelial lining and prevent reclosure. And everyone should have thorough knowledge about the mechanism and design is essential in choosing appropriate stenting. Thank you.
Thank you very much, Doctor. I mean, I found it very interesting. I don't know what all of you are pretty familiar with it. You said about the extrusion of the stent. Could there be any choking experience rarely?
The patient coming with choking, you mean?
Because it's gone behind?
No. It's not in the throat or in the respiratory tract. It has just gone back in the mucosa itself. So a patient doesn't have choking, but I have some patient who have swallowed it.
Yes.
Yeah.
Yes, Dr. Arvind.
In view of time, I'm just going to ask a quick question to Dr. Javed. I know your work on biofilms and removing all these stents. Is there a scientific study or a period of time for which these stents should be retained? Because I think we all agree on the indications, but when we remove the stent, it is dependent on a very subjective scale. So do you have a time frame for removal of the stents?
Usually the biofilms on lacrimal stents start developing by 4 weeks and they get well established by 6 weeks. So I usually don't use beyond 4 weeks for routine DCRs, and for regular canalicular thing, if, especially those cases with ICID or recurrent ICID or complicated kind of cases, I keep it at the most for 6 weeks. In the rare event, if I have to reuse it, I remove it and place it a new one back. Because what happens is that the biofilms then starts mounting an immune reaction to the host tissues, which is what we don't want. We don't want inflammation in those tissues, because then when you remove the stents, there's a very good chance of reocclusions. So 4 to 6 weeks is the usual time, but then it's individualistic. When I was as a fellow, we used to place it for 3 months at that time when we were with Dr. Honavar. But that practice does not have evidence base. Evidence-based practice says 4 weeks as of now.
And Dr. Javed, you also worked on assessing the ostium, and serial assessment of the ostium shows that it doesn't reduce in size any more beyond 4 to 6 weeks.
Yeah. So what happens is that the epithelialization usually completes by 1 week of the DCR ostium. So, and then there's a little shrinkage that happens by 3 weeks, and beyond 4 weeks, serial assessment up to 2 years have not shown any change. And then we also looked at rabbit models, where we created rabbit models of canalicular injury. And when we studied histopathologically so we did canalicular nice cuts, just like a canalicular injury. And when we looked at the stents, we found that most of those canaliculi heal by the end of 2nd week. So again, 4 weeks can be a safe margin, even if it's a canalicular laceration.